Let's see. Our next study will be the use of anti-PD-1 antibody, MK3475, recently renamed pembrolizumab, in patients with advanced melanoma and the impact on prior ipilimumab therapy. The lead author, Dr. Antoni Ribas, a professor of medicine at the David Geffen School of Medicine at UCLA, will present the results. Thanks, Tony.
Thanks, Steve. And yes, the new name of this agent, this PD-1 blocking antibody, is pembrolizumab. It's been approved by the International Naming Convention. It substitutes the code name of MK3475, which is what's on your handouts. But please use the new generic name. Last year, transiently was called lambrolizumab, and I'm sorry for all of this confusion. It was approved by the U.S. naming convention, naming agency, but not for the international. It may sound like another limumab in some language, I don't know. So, but I'm happy to present the data, the expanded data on this study. And Dr. Egermont has talked to you about. Where's the mouse? Okay. Sorry, the mouse is hidden. Dr. Egermont has talked to you about ipilimumab. I think I'll have to point. Ipilimumab is an antibody that's blocking an early break of the immune system when the immune system is being trained. The immune system is made by T cells that have the right ability to recognize the cancer. They're usually turned off so our immune system doesn't attack itself. And an early break at the activation of these immune system cells is CTLA-4, so ipilimumab blocks here. Once you release that, it makes sense that you will have T cells that have multiple specificities, hopefully some of them going to the tumor and some of them will have other specificities. But once those T cells get into the tumor uses a program that's developed by nature to limit inflammation, which is the expression of PD-L1, which is a do not kill me signal. It tells, I'm here, I know you're here, immune system, don't kill me. And that turns off the T cell through PD-1. So pembrolizumab takes away this later break. The anticipation would be that it would be more targeted to the tumor because it's specifically for the T cells that are trying and ready to attack. And it should work earlier and faster. And last year, we reported the phase 1 trial, 135 patients with an overall response rate of 41% and good tolerance. This year, we report on a larger group, 411 patients, the largest phase 1 clinical trial ever done in this disease. And together with the lung cancer cohort in this phase 1 trial, it gets close to 1,000 patients. So the largest phase 1 trial ever done in oncology. This is the waterfall plot. Waterfall means patients, each one of these columns is a patient. Going down are responses or shrinkage of the tumor. Going up are the patients who have progression of the tumor. And you can see that majority of patients are on this side. The inflection point is at 72%. The objective response rate is lower. The objective response rate is taken the convention for assessing responses to chemotherapy, which is different from immunotherapy. So we use the chemotherapy convention, and then the response rate is 34% overall, and it's 40% on patients who are naive to ipilimumab, 28% on patients who are previously treated with ipilimumab, which these are non-randomized cohorts, so we don't know for sure if those are the final numbers. But it tells us a remarkable high response rate for an antibody that hits the immune system, not the tumor. It doesn't do anything to the tumor directly. But why we're excited about this is because of this. This is what we call the swimmer's plot. Patients start here, and each one of these patients goes as far. And the arrows mean patients who continue to respond at the time of reporting. The data cut is from October 2013. At that time, 88% of the patients who had responded continued to respond. The follow-up was a month and a half to 18 months with continued responses and counting on. This is the overall survival plot. The first time we showed this. This is taking the full 411 patients, regardless of if they got treatment or not, and followed them over time. We used to say that melanoma had a median survival of 6 to 9 months. That wasn't that long ago. Then we said, well, maybe it's getting closer to 12 months. Well, here we have not reached the median overall survival. The survival at 1 year is 69%. I don't have it here at a year and a half, which is the The latest reliable number, it's 62%, so it seems to be plateauing somewhere there. Obviously, we have to follow longer. What's the drawback? Here's the table of toxicities. I don't have time to go through all of them, but I can go to the bottom line. Grade 3 to 4 toxicities of 12%. This is one of the most benign therapies I've ever used in my clinic, and you're seeing the benefits. If you had to ask me what's the main toxicity, grade 3 to 4, well, they're all 1 to 2% frequency. The greatest one is fatigue. The most common any grade toxicities are fatigue, pruritus, and rash. So in conclusion, I'm reporting on a large number of patients. So this is the error bars that get very tight because we have a lot of patients treated in many sites. I think it's around 20 sites around the world. 34% objective response rate. These are patients who are, some of them have been treated with multiple lines of therapy. They're treated with different dosing regimens. It's the phase 1 trial. We still don't know how best to give it, and we're already getting these spectacular responses. 40% response rate in EP-naive, 44% in previously untreated patients, 28% in EP-treated. Majority of responses are durable with an overall survival that we still haven't reached the mean, and we started this in November of 2011. So thank you very much.
Thank you, Tony. So this is the second anti-PD-1 antibody. The Nivo has also been presented, BMS's antibody, at this meeting and in past meetings. And the data is remarkably similar with this approach. Remember, this is just blocking one checkpoint, and yet in melanoma, as you saw from those waterfall plots, about 2/3 of patients appear to be getting some clinical benefit, meaning stable disease or shrinkage. And there's objective tumor responses in almost 40% in this series. The other important point, I think, is that in this study, the prior exposure to ipilimumab doesn't seem to have any dramatic effect on the ability. And this is critical to us understanding whether combining or sequencing these drugs, because there doesn't appear to be a lot of cross-resistance between ipilimumab and PD-1. Now, you're going to hear that the combination may be even better, but the sequence is also potentially very helpful. And the remarkable thing, as you saw, is these almost 90% of these patients are having durable responses with a toxicity profile that's almost unheard of in metastatic cancer of 10% to 12%. I mean, this is really extraordinary about this class of drugs. I just want to reiterate that.